Yes. You were mentioning about the international conference. When are you planning the one?
In May.
In May. Okay.
3rd, 4th, and 5th of May.
Okay.
So I will come to Nagpur once to meet you.
Yes. This will be really a great meeting. We'll just organize a short meeting also. And what are the topics you are planning? So
it's the theme is infertility, ma'am. That's why.
Okay.
So,
Wonderful.
and we have the live surgical demonstration for the fertility conserving surgeries.
Okay.
And we have the PGs for the workshop on hands-on training for hysteroscopy and pelvic trainers. So it's a 3 days conference. And our special guest, Dr. Norman Gomez from Spain for the hysteroscopy. Yeah.
Oh, great. You're doing really a great, wonderful efforts. I think you're heading beyond Foxy, actually. You should.
No.
That's a great spirit. Actually, I could see the local body is also performing so well this time now. Yeah, they got awards also. So that is very, very praiseworthy for them also.
But I think we can be when we are together and performing such kind of activities. I think these are very important for all the fraternity to look forward for the integration purpose point of view. That we are making some, involvement of integration in our pathy, so that we provide more better kind of a treatment for our people, especially if it comes to infertility. Then definitely.
Yes. So I even feel like there should be integration so that the patient will be benefited more, actually.
Yes.
That should be the agenda. Like I really believe, like most of our treatment, like we always look into like M2 tone will be a better than many other thing. Always. It is in my pen, like every other patient where I feel that she needs a menstrual regulation, she should go for this.
Yeah. Thank you so much, ma'am, for appreciating. And Dr. Jagruti, please request in all the groups to join, as our guests already have joined, so that we can start on time.
Can we start trying the screen sharing? Like I think they are.
Sharing can be done.
आगे गेले नाही देवबाई म्हणजे चांगलं लाईट जर बिल्ड वाला प्रॅक्टिस मोड बघा कोणाला बसवते मग असं पुढचं विचारा ना
Hello, ma'am. Dr. Shilpi
शेयर स्क्रीन गया तो फिर सीधा आ
अच्छा कर दिया है मैम। वो वीडियो कॉल चालू से
Ma'am, you
आते
can
हैं।
start sharing your screen.
Yes, yes. ये हटाना कैसे होगा क्योंकि ये दिक्कत है।
It is clearly visible, ma'am.
Hello.
Hello.
Yes, yes. I have shared the screen.
Yes, ma'am. It is clearly visible.
Yeah, yeah. Thank you. Thank you so much. Since morning, I was literally struggling with my videos. They were not able to run in my laptop. So I just revised them and I wanted to work with them.
Okay. If you have
If
any,
it's not there, ma'am, no problem. After your explanation, we can share it in our group.
Yeah,
If you
yeah. It's there. They are there now. No problem. They are there.
okay, okay.
Anytime I can. Yes.
uh, good evening, Dr. Priyanka, ma'am. Should we start or wait for a few minutes?
Just a 1 minute and then you start. I will send a message in all the group because after 7 they will join. Okay.
Yes, ma'am. Yes,
So
sure.
just 1 minute and then start and we will continue. Okay.
Okay, ma'am. Thank you.
Yeah. Yeah. Jagruti, you can start.
Okay, ma'am.
Yeah.
So, good evening, everyone. Am I audible, ma'am?
Yes, dear. Continue. Yeah.
Thank you so much. Good evening, everyone. I feel extremely glad to welcome everyone to this much-awaited webinar of this blockbuster webinar series by NIMA OBGY Center. Just a second.
Jagruti, mute everyone. Huh?
Yes, ma'am.
Before you start, mute everyone.
Yes. Yes. Okay. Thank you. So I feel extremely glad to welcome everyone to this much-awaited webinar of this blockbuster webinar series by NIMA OBGY Central. Myself, Dr. Jagruti, coordinating today's webinar with Dr. Aarti Nadar. Before starting our session, I request all the dignitaries and all the participants to take a moment for blessings of Lord Dhanvantari. Shankham Chakram Jalaukan Dadatamrutagatam Charudurvishchaturbihi Sukshma Swachhatirudyam Shukaparivilasan Maulimam Bhojanetram Kalambudujvalangam Katitatavilasaccharupitambaradhyam Vande Dhanvantarintam Nikhilagadavanam Praudhadavagnineelam Praudhadavagni. So, may Lord Dhanvantari bless us all with good health and success. Let us continue and begin this webinar. On behalf of NIMA OBGY Central, I welcome to all dignitaries and delegates for today's knowledge-enhancing session on the topic of challenges in uterine anomalies. First of all, I welcome Dr. Ashutosh Kulkarni sir, President of NIMA Central, Dr. U.S. Pandey sir, Secretary of NIMA Central, Dr. Shantilal Sharma sir, Treasurer of NIMA Central. Then I would like to welcome Dr. Kamini Dhiman ma'am, President of NIMA OBGY Central, Dr. Priyanka Nakde ma'am, Secretary of NIMA OBGY Central, Dr. Vishnu Bhavne sir, Treasurer of NIMA OBGY Central, Dr. Rajesh Utne sir, Convener of NIMA OBGY Central. So before we go any further, let me give few instructions that are common for all the participants. So please keep yourself muted during the session. If you are found unmuted or disturbing the speaker's voice, you will be either kept in waiting room or removed from the session to maintain decorum of the program. If you have any question, put your question in the chat box or raise your hand during the question and answer series. So dear all, as you know, today's topic is challenges in uterine anomalies. Today we are very lucky to have here with us a distinguished clinician, Dr. Shilpi Sood ma'am. Dr. Shilpi Sood ma'am is consultant and managing director of Safal Hospital and Diva Infertility Center, which is especially running for high-risk pregnancy management in fetal medicine, and it is also the advanced fertility and laparoscopic unit. She is also consultant at Wakhat Hospital, Nagpur. She is also past secretary of Indian Infertility Society, Vidarbha chapter. She is also past vice president of Nagpur OBGYN Society. She is a faculty at many national and international conferences. She got many awards like gold medal during the MD PGI in IMER Chandigarh. Also at JNJ, she received Dhanvantari Award for exceptional contribution for pregnant women during the COVID. So, with due respect to all, I would like to call upon Dr. Shilpi Sood ma'am to please deliver today's lecture. Thank you so much. Welcome, ma'am.
Dr. Shilpi ma'am, you can continue.
Mute. Yes. Good evening, everyone. Once again, thanks for giving me this opportunity to present at this very important platform where I can see very good number of and good topics to be discussed. I thank NIMA OBGY Society, Central Society. I really thank Dr. Kamini Diman, Dr. Priyanka, Dr. Vishnu, and Dr. Rajesh, and all the seniors for being here and coordinators for coordinating for the same. Now, today I will be really talking about some very, very different topic. In fact, this is one of the topic when you see such patients landing in your OPD, then you really mind get twisted what to do and what not to do. This is my past experience in last 20 years. First of all, what is the diagnosis, clinical, and you can say the investigations we need to do, and coming to the accurate diagnosis and challenges meeting the outcome of this particular condition, where the patient usually when present with this condition during for fertility treatment. So I do believe the process of reproduction, including sperm transport, embryo implantation, fetal growth and development, and the process of labor and birth relies structurally and functionally on the normal uterus. We all know that normal uterus can only take part with such activities. So any uterine abnormalities, including the congenital anomalies, can influence such activities. While most of the patients with uterine abnormalities have normal reproduction, we can say they have a normal reproductive outcome, but you can see but some may experience adverse pregnancy outcomes, although the underlying pathophysiological process is mostly uncertain. Coming to this background, I would like to say these are the anomalies which are defined as deviation from the normal anatomy resulting from embryological maldevelopment of the Mullerian duct. You can see that knowledge of embryology to identify the uterine abnormalities and abnormalities of reproductive tract is very, very important. And what is the basic process of formation of reproductive organ, especially the Mullerian organ like uterus and the upper 1/3 of the vagina. We can see the 6th week onwards, you can see like these Mullerian ducts are chosen. 4th week onwards, you can recognize that primordial, basically primordial follicles, they come from a primitive germ cells which arise from the dorsal part of the yolk sac. They participate in formation of primordial germ cells and they migrate towards the primitive gonads that is going to form the ovary. And that is being selected when they realize that this is a female, there is a lack of Y chromosome, this is going to be a female. And when this female is coming up, there will be a, you can see there is absence of testosterone, and you will see the lack of impact testosterone, and there is more of AMH, which leads to further development of mainly the Mullerian ducts. So Mullerian ducts participate in formation of reproductive organs, but the Wolffian ducts, they regress. So Mullerian ducts from fallopian tubes to the part of the body of the uterus on either side and towards to the upper 1/3 of the vagina, we understand very well. Now, 6th week onwards, there is a Mullerian duct formation, and there is a formation on 9th week continues, and during 10th week of intrauterine life, there is a fusion. You can see the both sides of the Mullerian duct are getting fused in the midline. And after fusion, although we can see the fusion, there is a division is there with the fusion, but followed by fusion. That is very nicely explained. There is a reabsorption, that is canalization of the cavity on the 16th week. After understanding this phenomena, then we will be able to classify the systematically the abnormalities we come across. So uterine anomalies are a challenge for the therapeutic decision-making process owing to the high prevalence and possible effect on women's reproductive health, as I already mentioned. So my learning objective for us in this particular lecture is to understand the prevalence of uterine anomalies, different classifications, diagnostic issues, mechanism of infertility, how they lead to infertility, and treatment options and their outcome. That has to be very well understood. And that is although up to the mark, like mechanism of infertility we can understand, but treatment options are really, we have to be very critical. Once for all, you have to decide, are you going to operate or not? What will be the reproductive outcome if you are going to operate? And we have to justify ourselves, we are doing best for the patient, we don't have to do any harm to the patient. That should be our final agenda. So coming to the anomalies prevalence, why it is so important to know that, like we can see generally, you can see 6.7 in the general population, you can see such anomalies, but it increases with this infertile population to the tune of 7.3, and you will see like 16.7, and one of the article I was going through in the morning, up to 25% it is seen between like infertile plus recurrent miscarriage combined, they will present as a 25%. So this population, they struggle with the end organ problem, because uterus is the end organ, that is the organ which is going to keep the embryo and have pregnancy. So, and also we do see the commonest is the arcade uterus is commonly seen in a general condition, and we have to accurately diagnose, and there is no tool to accurately diagnose, and may lead to recurrent miscarriages in the population. And sometimes we are not very sure, is it because of arcade uterus or something else? So we have to rule out many other cause before really correcting the arcade uterus. That is the important point I would like to mention here. And then coming to the septate uterus, which is very, very commonly seen in infertile population with congenital uterine anomaly. We do see many such patients we diagnose with a hysteroscope, HSG, and then a diagnose. The 3D ultrasounds we do routinely when the patient is having a history of infertility with recurrent pregnancy loss. We do come across this septum, because these days 3D ultrasounds are very, very nicely done and very clear with the page. And our radiologists, sonologists are very tuned to the 3D ultrasounds, and it is a very good modality to diagnose the septate uterus. And I do believe when there is a recurrent loss and infertility, doing a hysteroscopy and curing this septum is very, 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 very like a good way of treating the patient, where the outcome could be very good. So coming to the classification, we can see in the year 2014, we got a AFS, American Fertility Society, which is now ASRM, has given this classification where they have categorized this into 7 classes, clearly starting from the hypo or agenesis. They have said there is agenesis of uterus, vagina, cervical, and every part, followed by only one side of the part has developed, that is unique on it. Either it could be associated with communicating or non-communicating on, and then with cavity and no cavity, that is the agenda. This is a very clear thing which we should keep in mind. Or there is a duplication, and this is didelphus, and duplication, full duplication is didelphus, and half duplication is bicornuate, which is complete or partial. Again, 5th category is septate, where is a lack of reabsorption. We see a lack of canalization. Either it could be a complete from vagina to the fundus, and or a partial one. And one entity of class 6 is arcade uterus, and there is a DHEAS exposed patient where they present as a T-shaped uterus. That is a one entity. But later on, Escher has given a different classification in 2019, and they have divided in different classes. Like they have given a class of U0, like that is a normal uterus. U1 is a dysmorphic uterus, that is T-shaped, infertile, other type of uterus. But U2, you can see the partial and the complete septum, and the U3 is the bicornual uterus again. And they have talked about U4, that is a unicornate, and finally hypoplasty U5. But apart from this, I must say there is they have talked about what is important in Escherichia. I think my slide has to go down like class 6, followed by unclassified varieties are there. What is the difference between AFS and ASRM and Escherichia is like Escherichia has focused on the cervix also and the vagina. So there is a cervical malformation and the vaginal malformations are taken into that, like cervical atresia, vaginal atresia. These conditions were also talked about along with the uterine malformation. Later on, now lately in 2021, again ASRM come up with the combined Escherichia and previous ASRM, where they have taken uterus, cervix and vaginal part together to understand the condition completely and put it in a one platform for the good diagnosis of these condition. Because if everybody use a single guideline, they will have a better diagnosis, better collection of data. And for research study, it is very, very important that we should have a latest guideline in hand for classification. So classification is very much required to have a synchronized diagnosis and putting up the and stratify the treatment also. That is very, very important. Now, coming to the diagnostic tools. Now, the patient may come with the clinical diagnosis of chronic pelvic pain or a cyclical menstrual pain or amenorrhea, primary amenorrhea. These are the clinical findings. We may have to do the clinical examination. We may have a clinical examination finding. If an unmarried girl, we have to do, apart from a general clinical examination, the PR examination to look for any like if the patient is having amenorrhea and there is a cyclical menstrual pain, she might be having a hematometra and hematosalpinx, and that can be done with PR examination. And then finally, apart from these, we have to be very specific with the diagnosis by talking about the various tools, because these days we have very good tools. Like, patient is landing up in your OPD and you are just examining. And after examination, a gynecologist can go ahead doing the sonography with full bladder in an unmarried girl. And you can simply go for a 2D scan in the first chance. Like in 2D scan, you can just quickly screen the things. How does the uterus looks like? And there might be, you may have a suspicion of something in the uterus, the broadness of the fundus. There is some two cavities as seen. So this can be taken as a screening tool, or a patient who is looking for an pregnancy and presenting as a infertility, and we are doing HSG, we may come across some malformation in HSG, like we may see bicornuate, uterine diadelphus, and these condition, and unicornuate shape. These are the screening tests, accidental diagnosis. But to be sure, you have to move ahead. For moving ahead, you have a better diagnosis by, you can do always, like if you have a suspicion, nowadays we have a better diagnostic tool like 3D ultrasound. Now, why it is better? It give a very good picture of the uterine cavity. You can see the septum, and you can just delineate the fundus and the depth of the fundus and the line. And this measurements from the corneal end itself suggest that this is a case of septum. If there is a dimpling of the fundus along, and there is a narrowing of the fundus here also, and there is a thinner myometrium at the fundus, that is a diadelphus cases. So we have to bicornuate cases, in fact, and we have to be clear with this idea. And 3D ultrasounds are very easily diagnosing, and they have a very clear picture. They are less invasive and they are less costly. Why I'm talking about less invasive? Because we have taken a tool like laparohysteroscopy as a gold standard for the diagnosis. But really, we may not have to resort to this if we have a very good 3D ultrasound in hand. But what is the role of MRI? If you don't have somebody who's doing 3D ultrasound, for the diagnosis, or if you feel like you have a doubt, like although it is a uterine malformation, either it is a bicornuate, septate, or something, there is a, I must say, like sometimes there is a rudimentary horn, whether there is a cavity or not, it is, we are not able to clear it very finely, then we may have to resort to MRI in those cases. Sometimes it is very difficult to ascertain, even in laparohysteroscopy also, the nodule is carrying the cavity or not, and there is a communication also. In those cases, when there is a complex uterine anomalies, we may have to resort to MRI for standby confirmed diagnosis. So I think everybody is so clear, like these tools are very, very important, and they are very good tools, and keep the diagnosis in hand with these tools to make your mind for the further diagnosis. So I must say 4 tips of correctly diagnosing the uterine anomalies are: know the embryology and nomenclature well, as I already mentioned, like you concentrate while designating the categories: formation, fusion, resorption. Accordingly, you can say formation, you may go with the unicornuate, and fusion one, if it is a lack of fusion, that is a didelphys bicornuate one, and there is a resorption problem, then you may have a septate. So this clarity in mind will definitely help you to have a better diagnostic approach. Now, second thing, define the external contour of the fundus. That is very, very important, on, if you are doing HSD. So HSD, there you only come to know the internal part of the cavity. So there you don't have an idea about the external contour. And for that matter, we are going for the 3D ultrasounds, and 3D ultrasounds gives the thickness of the musculature at the fundus and towards cornea. So if there is a good fundal thickness and narrowing towards the cornea, this is it. And but the thickness which is protruding inside the uterine cavity, and later on it is tapering towards the cornea, and that is a case of septate uterus. So external contour is very important, and we do see come across in laparoscopy. There is a broad fundus in septate uterus, because fundus is slightly, get tense with the septum pushing it inside the cavity, and there is a broadness in the fundus being noted. So that is important point when we take things in knowledge. The third one is compare the fundal, as I said, fundal myometrial thickness to the corneal myometrial thickness. So you can see this is a fundal thickness, TF, and you can measure this measurements. TC is the corneal thickness. If you subtract compare these one, there is a difference of 0.37, and this is here there is a, you can see very minimal thickening changes. There could be a arcuate uterus, but a more than that, a higher thickness difference will give a more diagnosis of a septate uterus if there is a wider difference is seen. Coming to next point is second, use of many technologies. When I have not mentioned that use of saline infusion techniques. Sonosalpingography can also help us to delineate this condition while doing, but with the advent of 3D ultrasounds, this is also not required for the diagnosis. You can see the very good pictures of unicornuate uterus. It is a banana shaped appearance of the intrauterine cavity, endometrium being shifted towards one side, and the single cornea seen. And here you can see, typically you can see the fundus is well formed. This is a septate uterus, and this is a bicornuate uterus. Dimpling of the fundus you can see, and here this is a case of bicornuate uterus. So after diagnosis, you have to have something in your mind, like whether you're dealing with a single uterine horn, or if there is a single uterine horn, then always look for the rudimentary horn. don't leave behind, okay, this is a unicornuate horn. That doesn't mean, but you should look for the rudimentary horn, or whether rudimentary horn uterus is having a cavity or not. That has to be looked into, because with a cavity there will be a painful cyclical pain will be there. But and the external surface should be seen, like widely divergent horns are seen in uterine diadelphus, and even in bicornuate uterus. But in if you see the internal part, you can have external cleft is seen, but sometimes it is a normal also. If this is more than cleft is less than 1 centimeter, that is normal uterus. More than 1 centimeter, and between less than, as I said now, this difference of thickness is an arcuate one, and if it is more than 1.5 centimeter, like this is a septate uterus. Then finally, whether they are a complete one or a partial one has to be a certain, like bicornuate can be a complete or partial. Similarly, septate uterus can be complete or partial. And some hypoplastic uterus meiogenesis has to be seen. If it is not seen and there is a persistent amenorrhea scenes, and then there could be a DHEAS related anomalies has to be sorted out. So you can create your own map. What is the clinical presentation? What are the imaging findings, and what are the difference? And then you come to your diagnosis. What is the final diagnosis put in your mind? Now, do congenital anomalies have an effect on infertility? You have to think on it. Now, you have seen the patient in the OPD, and then you realize, now I have to go for the tubal evaluation, and you have ordered the HSG, and the patient comes with the HSG saying a unicornuate horn. What is your lookout for these patients? Then you have to go back to your history and look for the menstrual flow. What is the amount of menstrual flow, scanty flow, and everything has to be noticed. And you have to rule out rudimentary horn. I'm just giving you this particular case why I want to put your head into. Now you get biased. Here you get biased, and you would like to indicate, like, look, this is looking like a unicornuate uterus, and you have only one horn, and the other horn is missing. And it does look that you have a very small endometrium cavity, and chances of receptivity of this endometrium looks could be little lesser than the normal one, and you definitely have a lesser space to accommodate the pregnancy and the growth of pregnancy. So this definitely comes in your mind, and you will consult the patient. But is it really this condition is because of this condition she has infertility? Has to be certain, because you do see like many of your unicornuate patient do conceive well, and they have a good outcome. In fact, a normal delivery patients, they even deliver normally, and they don't, you never ever come across like she's having a unicornuate unless you do a cesarean section. And during cesarean section, you can come across like, now, okay, this is a unicornuate. There are either widely placed tube or ovary in one side, or there is no tube and ovary on the other side, only one side of the horn and tube and ovary is seen. So this is the dilemma we have. And I must say in this lecture, don't get biased, be easy, do consult. It could be a cause of infertility. Have patience, keep working with the patient. I know one of my latest patient is coming with this, like, I am not biased, don't want to do. Only thing I told her, like, if you won't conceive, I try to work out with the hysteroscopy, try to enlarge the endometrial cavity and improve the chances of. But she had one conception missed, followed by again I tried on her. Then again she conceived. Now she's carrying 8 weeks of pregnancy. So you must keep on trying rather on working on the uterus. That can help you to have a good outcome. So what could be the potential mechanism and potential association and probable underlying causation for the infertility need to be worked out. So possible mechanism is Uterine musculature, fibrotic areas, not allowing the implantation, effect on the endometrium in its receptivity. Uterine vascularity might be changed and not giving a good implantation bed. Uterine contractility might be affected, receptivity, as I mentioned, and these all increasing the pathology leading to endometriosis also, because abnormal passage, abnormal deposition of menstrual fluid in the peritoneal cavity can affect and lead to endometriosis, which could be an indirect cause of infertility. So, possible association may exist if the prevalence of congenital anomalies were greater in infertile group compared with fertile. Yeah, we do have this in greater in infertile groups. So, there is a possible association. Fertility more likely amongst these patients who have anomalies, prevalence, diagnosis again, but if but and all keeps on going and we have to keep on working. So what is the probable underlying causation is cause-effect relationship. So this is the cause. Is it really affecting the infertility? Has to be judged. The presence of, we do understand they may lead to infertility. Is it really the cause of infertility? Has to be ascertained. Consequently, treating the anomaly would lead to an improvement of infertility or not, has to be judged very, very minutely, and we have to be really for the patient we are god. If we are doing something wrong, that really the uterus will be lost for the implantation. That is the point to be taken. So associated pathologies, what could be there? Coming to next point of the discussion is such Mullerian abnormalities are associated with urinary tract malformations also. You know, the Mullerian and urogenital, these are hand-in-hand developmental organs. So any such Mullerian problems may have a renal problem also. To look out for these malformation, kidney, ureter, and their duplication absence has to be seen. And then endometriosis and polycystic ovarian disease. So one very important take-home message here is such malformed uterus have a sometimes have a smaller cervix, and they also have a incompetent cervix. So while handling such cases of anomalous uterus, we have to have cervical incompetency to be in mind, and such patient who conceives, they should undergo a proper cervical screening, monitoring, and like look out for encirclage in such patients, like they have a higher chance of mid-trimester abortions also. So what could be the surgical treatment? Coming to very clear now, you have given a good trial, the patient is not able to conceive. As I said, I have given a best trial to my patient who's coming for unicornuate uterus, but now she has conceived, and I am very much alert. Like I need to supplement, like whatever pathology I has mentioned, like fibrosis, loss of the abnormal vasculature, and the you can say contractility. So for contractility, I have supplemented with to make the uterus silent. I have supplemented her with progesterones. I have given for better vasculature and better flow to the embryo. I have given the ecosprin, and I have also planning if she moves on very nicely, like at 12 weeks after NT scan and screening out her baby for genetic screening, and then I may look for the like cervical screening also. Cervical length has to be monitored every now and then, and at one stage I feel no, it is a very precious pregnancy, I may advise a cervical encirclage and consider for this method. So after asserting the diagnosis, we may have to plan. If you see like patient is not able to conceive, then you have to go for the surgical method, and that is hysteroscopy. So what is the time of hysteroscopy? Is the early proliferative phase. Because hysteroscopy has a dual role now, it will help you to have a diagnosis where you are not very sure. So you will keep in mind, like, yeah, I may have to have a good diagnosis, and side by side I'll be operating on it. So we may also plan for, like, if to avoid blood loss, some of the surgeons also look for pre-operative preparation with GnRH to have a reduced vasculature and less bleeding. And there should be better equipment, smaller diameter equipments to have a better outcome. Preoperative cervical ripening also you can look for, but these days we have a very finer hysteroscopic surgery where we don't look for the cervical ripening with mesoprost and all, but we look for if we really suspect there could be a chances of cervical stenosis, there we can work on it, or we should directly look into the internal os with the hysteroscope and cut they open the cervical internal os with the instrumentation. That is a better idea. And diagnostic hysteroscopy and primary assessment and evaluation of volume and morphology of uterine cavity is very, very important. Look up and down, side by side, osseous, and all the walls, and correct assessment is important. As I said, in unicornate uterus, what type of surgery you will look for. So I'll be showing few videos like surgical technique for the uterine anomaly, which is the most commonest at the uterine septum. You can clearly see the septum. This is a right cornea. This is a left cornea. And there is a clear septum, partial septum is seen. And this looks, although a fibrous, not very vascular, the cold scissors, I'm cutting with the cold scissor, I'm doing a septoplasty. And after doing a septoplasty, you can see in this video, like scissor is easily cutting the fibrous septum. The bleeding is less bleeding is seen. And during the surgery, you have to keep yourself in the middle, avoid going to the up and low. And at the end, your aim should be to cut up to the level where in the panoramic view, you can see both the ossea together. So this is a nice way of resecting the septum, like you can say cutting the septum and clear the cavity and give the voluminous cavity. And what is very, very important, after doing the surgery, you should be, you should be well prepared. This might bleed. If you're prepared, then you can always supplement with the tranexamic acid and all, and followed by you can do tamponade with the Foley's balloon, or if nothing is there, like you can simply create a good cavity, and after that, if you really feel like there should not be re-adhesion formation, addition has to be avoided in these patients, and we have to take utmost precaution in such cases. I'll be coming to those cases, like how these post-operative management has to be given. Ideally, these days, now we are not going for a T placement. This is a colon knife resection of the septum where we suspect there is a vascular septum, then we do a electrocautery resection. This is now keep your instrument in the middle, keep visualizing the cavity simultaneously, and try to cauterize carefully with the assessment of the depth. So such surgeries are very, very precious for our patients. And if any time we come across there is a risk of perforation and uterine wall damage, injury is there at that time, we have to really stop the procedure, and we could not complete the procedure in the same sitting, and then we have to come back to the next sitting after the healing of that particular wound. So we have to be very cautious, as I said, in the formation of cavity, post-procedure bleeding, and then taking care of good endometrium formation is very, very important. Lining formation. Earlier, the simple T was placed, or somebody was placing the Foley's for 7 to 10 days, but there's no need. If you can give estrogen, you can say you can give estrogen 2 milligram BD doses for 3 months continuously. There is a growth of endometrium nicely. So this is the way we do the surgery, and we try to bring up the endometrium, and in further cycle we keep on judging the endometrial growth, and the response to the treatment has to be seen, because after that you will see there is a very good trilaminar endometrium is seen in those cases. So this is the surgery for septate uterus. No, higher conception rate after hysteroscopic metroplasty is a case of, in a case of unexplained infertility is seen, where you realize there is a septate uterus. If you do septal resection, there is a more chances of conception. So there is an association also with the length of septum and infertility, higher conception rate after correction of complete septum is well proven, and hysteroscopic metroplasty should be advisable before an IVF cycle to improve the pregnancy rate and reduce the incidence of spontaneous abortion very much. So I must say, like, coming to the another entity, dysmorphic uterus. So for septum, it is one for all, like septoplasty. But what about the other uterus we do come across these days? T-shaped uterus. They quite often we come across when we do the diagnostic hysteroscopy in a patient going for a IVF cycle. So there you can see the lateral wall is coming inside the cavity, is convergent. So there is a tunnel-shaped cavity, ossia locate far laterally, and inability to visualize both ossia in a single view is seen. Now you can see the Pauline life is working on the lateral wall. So sharing of this lateral wall and improving the cavity volume. This part is cut. This part is cut on other side and uterine volume is resorted. So the idea is to cavity volume is improved, and that improves the chances of conception in these cases. And quite a few studies are saying this is giving a very good results in further implantation. And one entity is the one being described by the Escher. There is infantilis uterus, a very small cavity. You can see you're moving towards the internal os, and there is a very tubular, it is not in fact T-shape, it's a tubular cavity. Then good assessment in 2D ultrasound, and the measurements of the the muscles walls, and then increasing the volume by doing the lateral metroplasty on other side, and the metroplasty on the fundus also. That will give a wonderful further improvement in the volume of the cavity. So this is a uterine metroplasty for uterine enlargement. You can see on either side, there's a lateral wall is being shared off, and this side also, on the right side also, and finally at the fundus, this is it. So the agenda is, after doing this surgery, you have to keep assessing the endometrium being built up on this cut site, and the covering of endometrium do come across, and you have to be very particular to avoid the adhesion formation. So you can see the cavity is now a bit broader when you have done the thing. And many of the time when we are not very sure about the things, in such cases, I personally believe when there is a very small uterus, there is a very high chance of perforation. So we have to be particular. We may add on the laparoscopic view also side by side to avoid any such incidences or take care of such incidences. So this is another important thing. You can look into this asymmetrical septum. The Robert's uterus is defined as a asymmetrical septum, where you can see the right side of the cavity is well formed. This is the right side of the cavity, and this is very well formed, but the left side of the cavity is now incomplete. It is not communicating with the cervix because of this incomplete septum. That is the entity we should know, Robert's uterus. We do come across such condition, but unable to diagnose. Now with this knife is cutting up this septum. This is sharing off the septum from this to this area. So the knowledge of the anatomy of the intrauterine part, and then working on those part and cutting this septum is really a challenge here. And the assessment of the surgeon, keeping the eye on the endometrium and on the ossia very nicely, will help you to do the surgery. Otherwise, it's not a very, very easy surgery to cut this asymmetrical septum, because in such condition, the patient also is menstruating, but cyclical menstrual pain because of accumulation of menstrual blood in the left uterine cavity, and also sometimes hematosalping. So this condition has to be noted when there is a cyclical pain, dysmenorrhea also, there is a menstrual bleeding, and then you can always do the 3D ultrasound and do further investigations to follow this thing. So another condition is a biconate uterus is a typical of the lateral fusion defect, constituting approximately 26% of uterine anomalies. What we do, that is a Stressman's abdominal metroplasty being described as a unification procedure, correcting the underlying defect of two uterine cornea in biconate uterus, making it a single cavity. Post-operative, either it can be done laparoscopically or open surgery. Post-operative fetal salvage is higher in these cases. It's 100% after corrective surgery was reported. Laparoscopic route is feasible, better an alternative to abdominal metroplasty. Now I can give you this picture of this Stressman metroplasty, laparoscopic view or diadelphus uterus, and you can see the nicely done Stressman surgery is then you can see, and there is a separation of both, unification of both the horns has been done. And truly speaking, it is really far dangerous to see the sutures all along from anterior to posterior, and we have to be very particular for the patient during antenatal period for carrying the pregnancy till term, and we have to very alert in 8 months where there is a high risk of uterine sutures being giving away and risk of fracture. You can see the post LACS, these sutures are seen here. I have taken this note because it is such an important thing to look into that. Like coming to surgery for unicornate uterus is annual surgical technique for trans-cervical uterine incision on the designed to widen the normal uterine cavity. You know, the normal uterine cavity is narrow and that has to be improved. To test the hypothesis that the adverse pregnancy outcome associated with unicornate uterus is related to the reduced cavity of the cavity in this group of women, we have to really put this head if the cavity is enough or not, and this uterine incision appeared to improve the pregnancy outcome in women who are having infertility or miscarriages have been proven. So you have to just judge. And there are also challenges that with the unicornate, that the non-communicating rudimentary horn with functional endometrium be removed, particularly in symptomatic women, and there is no consensus whether to remove communicating rudimentary horn or horns without functional endometrium has been given, but you have to be careful while looking into these cases. The patient may come across very acute abdomen and we have to do a emergency surgeries when these patients present with non-communicating horns. But there is no evidence that removal of such rudimentary horn improve the reproductive outcome, because those are communicating horns. They need not to be removed because they are there, but there are chances of rupture uterus in these horns when they have a weakness of muscle, but has to be justified by imaging techniques and the diagnosis. But no strategy has been there to remove these horns where there is a communication. So what is the role of laparoscopy in these surgeries has to be limited. Sorry. The use of laparoscopy has to be limited to those cases with concomitant pathology that requires laparoscopic approvals, like endometriosis, some fibroids, or some condition, or they have a complex uterine anomalies, or it can be as a guidance method in case of hysteroscopic metroplasty for septate, as I mentioned earlier. So post-operative strategies for adhesion prevention is surgical technique should be good. Early second look hysteroscopy can be done. Antibiotics should be given properly. Preoperative hormonal endometrial suppression can be done. Postoperative hormonal treatment, that is the most important, and postoperative antibiotics. And patient should go for barrier method, no early conception. Intrauterine device, balloon, and these are conditions being mentioned, but these days we don't use all this thing, and good hormonal support is everything. So reproductive outcome after correction is conception rate really improves up to 40 to 60% attributed to the improvement of the uterine cavity, morphology, and volume mainly. Other factors like endometrial injury induced by biopsy or scratch or hysteroscopy also help in conception, because it is being said that improves the inflammation and implantation in these conditions. But there is also a risk of uterine rupture in subsequent pregnancy if we have not taken care of those, and in like uterine injuries like perforations or post metroplasty, Stressman's metroplasty. And so for that matter, Also, the cervical incompetence in such patient, we should have a very good, careful obstetric management to give the live birth pregnancies. So I must say, I just want to share a few more my experience, like how do we find such patients in cesarean section? 60% of the pregnancy in unicornuate and didelphys group reach term, and 60%, 39 in bicornuate and 48% in septate. And you can see this, as I said, like this is a I can say the horn being cut open and seen. This is one of my cases. I have taken, and this is a bicornuate uterus. You can see the bicornuate uterus. And the cesarean section was done in one uterus. So now what is the call I was discussing? If there is a communicating cavity, whether to remove the rudimentary horn or not, it is being literature says no need. But if you, it's really a no need. But if it is a non-functioning, this is known to you in beforehand, then non-functioning one has to be removed. Now this is a case of, again, uterine didelphys. Yes, you can see the two separate cavities up to the, this vagina. You can see the two separate cavities. It's very, very well seen. So there is a one uterus was showing the pregnancy. Now this is a bicornuate uterus where both the uterus is carrying pregnancy. This is a twin pregnancy. This is a wonderful picture of today's lecture. I would like to share, like two twins were delivered in both the horns. This is really a big thing, and cesarean section and cesarean scar is being seen. So I must conclude my today's lecture. Like, I know diagnosis, simpler clinical diagnosis, simple approach, and a good hysteroscopic surgery and the use of laparoscopy when indicated need to be done, but not always surgery. We should not always incline on the surgery. We should always prepare our patient whether she's able to conceive without anything to be done. So we must pledge here again, first do no harm, don't treat without indication, only do surgeries when it is indicated. That is my message to everyone. And I conclude saying thank you again for this wonderful, giving this wonderful opportunity to me. Thank you so much.
Wonderful session, ma'am. Absolutely stunning. And the beauty of this session was your own experiences and your variety of the patient that you have shown in this platform. It was great. We have seen some patients first time, like the bicornuate uterus that you have shown us the last picture. That was very nice. Very appreciating that you have a very good variety of the patients in your clinic also. Such a roaring practice that you have in Nagpur, and we are absolutely overwhelmed with this your topic and your sharing experience. So I would like to request Dr. Jagruti. Yes, please take the question.
Yes, ma'am. Thank you. Thank you so much, Dr. Shilpi ma'am, for this wonderful and very informative section. So if you permit, we start the question and answer series. So I request Dr. Aarti Nadar to take question and answer series. Over to Dr. Aarti.
Yeah. Thank you, ma'am. Please, anyone, if having any doubts, please put it in chat box or directly please unmute yourself and ask the questions.
Aarti,
Priyanka ma'am, if you have any questions, please ask. Yes, ma'am.
Yes.
Hello.
I just want to hear some points regarding the MRK syndrome, ma'am. If you can.
Yes.
Yeah.
Yeah, very nicely. Like, we do come across MRK syndrome. That the syndrome has a type 1, type 2 varieties. Like type 1, we could see, like, there is the formation of uterus is there. Like, they are in the form of nodules. There is no unification is absent. So you can say there is non-functioning 2 nodules or a single nodule you can see without any endometrial cavity. That is type 1. Type 2 is basically this is basically because of the absent functioning uterine cavity. So type 2 is no uterus basically.
No
Uterine, no, even there is no nodule, there is an absence of uterus. Only the ovaries are formed and they are spread out widely on the lateral pelvic wall. And in these cases, there is also, you can see the absence of the upper 1/3 of the vagina, or
Yeah.
sometimes there is a complete vaginal agenesis. Now,
Yeah.
you do understand, like upper 1/3 is formed from this Mullerian duct, and the lower 1/3 is sinovaginal bulb, which is forming the vaginal plate, and that unification of these two tubes gives the final vagina formation.
Yeah. And in such cases, ma'am, whether we should, means considering her not a reproductive but sexual life, if we consider, when we should perform the surgery is, shall we perform during means the marriage is concerned, or when she wants to have a partner, at that time we should perform a surgery, or we should perform it before? Is it, means what should be the best?
Yes, it's a wonderful question. I think it's very important. Like whenever you come across such patient, you have to see whether she's married, unmarried, and what are her prospects to go for marriage. That, you know, the only thing, like you have to do the surgery 6 months or 3 months prior to marriage accordingly, like what type of surgery, like McIndoe's pulling of the peritoneum you have to do, or a vaginal resection, or skin grafting you want to plan, or you have to go for the sigmoid colon implantation. The 3 different types of surgeries are there depending on those, like those where we have a vaginal canal formation and the skin grafting, there they need more of dilatation techniques.
Yeah.
And then McIndoe one is also need little bit of dilatation. These are, but the sigmoid colon one doesn't need much of dilatation, can be done early, but those techniques where they need more dilation has to be done 6 months, 3 months prior to the marriage actually.
Yeah. And if, as you say, for the complete septum, if we consider, and we are, if we are doing a septum resection, at that time, what precaution we should take that the patient should not come across for cervical incompetence?
Yes, ma'am. This is very, very important, again, point. But, you know, she will definitely land up into cervical. You cannot take much of the precaution, but what you can do, what is the idea the surgeons have put up, and we have a discussion in our group, like you can cut the vaginal portion, and then you just leave behind the cervical portion, and we can move ahead doing the lower uterine and upper uterine septum cut, and leave behind the vaginal septum to avoid the incompetence. This is one of the strategy being followed up. But we have to make sure, like cervical length has to be monitored very critically. And if you really don't want to take any risk in a patient who has already have a bad obstetric history, go for cervical length circulation.
Okay.
Sorry to interrupt. Ma'am, it's a similar question according to the age. If the patient comes at pubertal age and accidentally she is find as biconjugate uterus, so should we advise the plastic surgery or united surgery at what age?
No. See, you know, anytime when you come across biconjugate, you know, for this patient whom you are mentioning, like she is unmarried. So first of all, you have to see with what condition she is presenting with you.
Okay.
See, if she has presented with you chronic pelvic pain, or a cyclical pelvic pain, or a primary amenorrhea with cyclical pelvic pain, then you have to come to a particular diagnosis. Is it obstructing, non-obstructing pathology has to be certain out. Like if you say it is a non-obstructing and there is a minimal pain, it could not be because of this condition. You have to rule out some endometriosis, which is associating complaints. So with the diagnosis of communicating biconjugate horn, don't do anything. Just treat the condition of associated problems. Leave her. She is a good candidate. She may conceive on her own. Let her get married and then have her own good time to conceive. And if she comes to you saying, I'm not able to conceive, just go for to look out other causes of infertility before really jumping into the surgery of biconjugate. This is the message I want to give everyone.
Thank you, ma'am. Over to Dr. R.
Thank you, ma'am. We have one more question, ma'am. Hypoplasia uterus, choice of treatment and selection criteria for any surgical correction, reproductive outcome.
Yes, yes. You know, we do come across a hypoplastic uterus. The definition is nowhere seen mentioned. One of the gynecologists once called me up, can you define the hypoplastic uterus? But I have gone through the literature and there is no real mention of the length with where we can say there is a hypoplasia or not. So we do come across our radiologists mentioning on the any uterus less than 5 centimeter, the length and the less. You can only be just defined with the length mainly, and there is hypoplasia, whether it is having a functioning endometrium or not. Two conditions. The hypoplastic uterus with a non-functioning endometrium is one thing where the patient might present with the primary amenorrhea. Then we have to really look into what is the reason for hypoplasia, whether the sex steroid hormone coming from the ovary is really not working on the hormones. So either this is a hypogonadotropic hypogonadism, we are dealing with the ovarian lack of FSH, LHS, and there is no function, ovarian function, no E plus P, no action on the uterus. So that may land up into hypoplasia. So anytime hyperplasia either could be a congenital condition or premature ovarian failure where we are not able to get the estrogen and progesterone can also lead to hypoplasia. So if you see there is a scanty menses or poorly performing endometrium, jump on that uterus and try to feed the uterus with what it wants. So it wants an estrogen basically. So estrogen has to be supplemented for long, ruling out other pathology. If she's you have to rule out other conditions like any family history of breast cancer, any gallstones, any other you can say these two important things, any like hypertension, and these three things are very, very important to rule out when you are putting a patient on a long-term estrogen therapy. But mind well, don't be afraid of supplementation with estrogen. They are mostly young and without these underlying conditions because they already lack estrogen. There is no such estrogen from ovary being given to the body. So you can frankly supply this estrogen from outside. So there you have to give the long course of estrogen, 2 milligram tablets. You can say BD dose for 3 months continuously, and then you see the growth of the endometrium by scanning. Or you can give 6 months or a year, and you can in between every 3 months you can do the withdrawal with the progesterone also to see the function of the endometrium. So with long working on these hypoplastic uterus, where you see there is a chance of functioning endometrium coming up, you can build up such patients. I must say once again, I want to declare one of my patients coming up with primary amenorrhea at the age of 40. She was primary amenorrhea, but at the age of 40, again, she lost whatever function she had in ovary. There were no function. I just built up her uterus. That was hypoplastic uterus around 3 to 4 centimeter. And then I built up gradually 5 centimeter, and she conceived with IVF early in the earlier time with the donor egg program, and she had a twin pregnancy. That was miraculous. Like this uterus carried up with the twin pregnancy. Ideally, we should avoid giving multiple pregnancy. They have a higher risk of mid-trimester abortion. So you should try doing a single embryo transfer or only 2, not 3. So, but she was a lucky one. She had a twin pregnancy, and that was a wonderful case for my lifetime.
Very nice. Very nice.
Thank you, ma'am.
Thank you.
Ma'am, we have another question like, can you please elaborate on hydrosalpinix formation, reasons, and infertility aspects?
If you want to talk about hydrosalpinx associated with uterine anomalies, I mean to say.
Yeah, ma'am.
Yeah, so there is a high chance of hydrosalpinx formation where we
Such
see
the question.
Yeah. We see the obstructive lesions. When you are coming across the obstructive lesion, there is a higher chance. If you have an asymmetrical septum or some rudimentary non-communicating horn, they may have a hydrosalpinx formation. Hematosalpinx is a more common and the higher chance of endometriosis. So these are the cases where we come across the hydrosalpinx, endometriosis. These are the associated pathologies. It's because of the evacuation of the secretions, uterine secretions, and uterine, basically non-evacuation of the uterine secretions due to obstruction.
Sorry to interrupt, ma'am. The similar question, if the patient is having bicornuate and unicolis uterus, and one horn is diagnosed as pyosalpinx and not treated by medical or conservative treatment, then what should be the next plan? Should we excise the one horn or?
Yeah, see, pyosalpinx, either it is, I think pyosalpinx means this is related to fallopian tube. Yeah. And the
horn is having the pus collection.
One of the horn. Is it communicating or non-communicating?
Non-communicating. Sorry, unicolis.
With non-communicating.
Yes, non-communicating.
If it is a non-communicating straightforward, you have to excise this horn. This is going to be nuisance if it is collecting a secretion either in the like premenstrual period, like before attaining a menarche, or the young girl may come across the secretions without the blood formation or hematometra, but she may have a secretion which landed up into the infection. Very rare condition to have a like you can say pyometra, but if you do come across, you have to, without communication, you have to excise this horn always.
Okay. And if it is communicating, then what should be the next line of treatment?
See, communicating horn, there you have to see, is it going to obstruct the conception or not, and what is the level of endometrium formation. Communicating may basically land up into the conception also. Conception, and there is a risk of rupture, then there is always, you have to have a 2D ultrasound. You see the weak musculature here, there is a very critical limiting line, whether this horn is a bicornuate good horn or a simple horn. A simple horn means is a weak horn. If it is a weak horn, then you have to excise the horn.
Thank you so much, ma'am. Over to Dr. Aarti.
Jagruti, we are lagging with the time right now. So
Okay,
take the
ma'am.
questions fast.
Yes, ma'am. Yes. Dr. Aarti?
Yeah, ma'am. Ma'am, we have another question. What about hypoplasia with premature? Yes, ma'am. We have another question. What about hypoplasia with premature ovarian failure and fertility outcome?
The fertility outcome is
Ma'am,
not very good. Hypoplasia with premature ovarian failure, as I have mentioned already, like they have lack of hormones, steroid hormones. We have to build up this uterus. Same question with the E+P for long term, and evaluate the endometrial cavity with hysteroscopically, whether the cavity is good enough, the endometrium is good enough, the receptivity has to be judged on. We do see the function of the endometrium, whether it is coming up with trilaminar pattern or not. And the endometrial blood flow has ascertained. And looking at all these criteria, we may try working up with the oocyte donor program, because this is a case of premature ovarian failure. So as I just now mentioned, like if we do these things, the chances of conception is there, but not very fair.
Okay. Thank you, ma'am. We have another question. Hydrosalpinx with endometriosis with primary infertility, what should be done first? Either laparohysteroscopy or first should we do HSG?
Oh no, never go for HSG. You know, you have already see
Ma'am,
how
am I
did you
audible?
you have diagnosed the hydrosalpinx on sonography and endometriosis also on the what is the size of endometrioma? If you have a size of endometrioma more than 4 centimeter, 5 centimeter, and there is a hydrosalpinx, it is not worth doing HSG. There is a high chance there is a tubal I can say tubal blockage with hydrosalpinx. But one very important point I must say in this meeting, like patient presenting with endometriosis has a very less chance of blocked tube. They have an open tube only. They present with edematous tube. So it is because of endometriosis this patient is having a hydrosalpinx. Our first aim not to do HSG. If you really want to look for the tubal patency, better do a laparoscopy, and side by side you can get away with the endometrioma. Or if you feel you don't want to do any surgical step and you are very sure about the endometrioma, you can work out with the dynogist and the medical management and regress the endometrioma, and then you can go with the if you are satisfied, like you have done good job, if it is less than 4 centimeter, then you can try giving chance of HSG. Otherwise, no HSG, only laparoscopy. That is the thing.
Thank you, ma'am. Ma'am, another question. How you treat medically to grow uterus?
The same question. I've given you E plus P. You want to know the therapy? 2 milligram BD for long, 3 months or 6 months. And if you want to give an in-between trial after 3 months, you add up the progesterone and withdraw and see what amount of flow is coming up. And then 6 months to 1 year, if you have enough time, you go for 1 year and you're satisfied. And after that, you give up the step up estrogen therapy like 2 milligram BD, then 2 milligram TGS, and keep on increasing the dose, and you will get the tri-laminar pattern of the endometrium. That means you are successful in bringing up the growth of the endometrium in a hypoplastic uterus.
Thank you so much, ma'am. Thank you for this wonderful session and as well as for answering all our doubts so patiently. So thank you so much. So on behalf of NIMA OBGY Society Central and NIMA OBGY Society Maharashtra body, I would like to express my gratitude to NIMA Central, Dr. Shantilal Sharma sir, Dr. Ashutosh Kulkarni sir, Dr. US Pandey sir for the remarkable support. I extend my gratitude to our NIMA OBGY Central President, Dr. Kamini Diman Madam, Secretary Dr. Priyanka Nakade Madam, Treasurer Dr. Vishnu Bhavne sir, and Convener Dr. Rajesh Chutane for supporting and guiding us to conduct today's webinar. I would also like to thank and extend my gratitude to our eminent speaker, Dr. Shilpa Shud ma'am, and who took such time from her busy schedule and delivered very knowledgeable and wonderful session. I would further like to extend my gratitude to our NIMA OBGY Maharashtra President Dr. Suhas Kelekar, Sir Secretary Dr. Manoj Gaikwad, Sir Treasurer Dr. Ajay Raj Balsra for all their support to conduct today's webinar. I would also like to thank Dr. Girish Daga sir for all the help and technical support. Last but not the least, I would like to thank from the bottom of my heart to all the delegates for their participation and presence. Without them, this webinar would not have been possible and succeeded. Now, with the permission of all the dignitaries, I am concluding today's webinar. Thank you for attending and hope you have learned and gained great knowledge from today's webinar. So thank you so much. So I wind up this session. Thank you, everyone.
Thank you.
Thank you so much, ma'am. Thank you so much.
Thank you.